All right, gang, trauma, orthopedic trauma, we're going to go back to that, and we're going to talk about the assessment and management of these guys. So again, your musculoskeletal trauma, just like any other thing we start to talk about, do your scene size up. Make sure that you've got your personal equipment on. Yeah, that's right, because if there's blood everywhere, you might want to have that stuff on. Make sure that you call for additional resources as you need them. And again, make sure, don't let the orthopedic injury distract from finding ABC problems, okay? If it was bad enough to break a bone or stick a bone through skin or dislocate something, assume that it might have done something to their airway, breathing, or circulation, okay? So make sure that you address all life threats, okay? Again, life and limb-threatening injuries. By the way, serious dislocations to the knee or elbow are limb-threatening injuries, okay? So keep that in mind, all right? So kind of determine whether or not you've got life-threatening injuries with minor musculoskeletal, or you got serious limb-threatening injuries. But remember, don't forget the life threats, okay? Make sure the airway, breathing, and circulation is going. Make sure that you've listened to those lungs. Remember, if it was enough force to break a bone, there was enough force to cause underlying structural damage, okay? So keep that in mind, okay? Evaluate the head, neck, chest, abdomen, pelvis. Again, remember the pelvis can lose up to 3 liters of blood. Consider a pelvic fracture if the pressure reveals instability, crepitus, or pain. By the way, pelvic fractures are a life-threatening emergency, okay? You can lose a lot of blood in the pelvis and not even realize, okay? Each femur can lose 1,500 of blood. So again, you got bilateral femur fractures, you could lose 3 liters of blood. There's a warning there. That's why it's a trauma alert, okay? Again, your extremity fractures, they can contribute to hypovolemia. And again, a rapid trauma assessment, you got to find the life and limb issues, okay? Your secondary exam, again, a focused one. If you've got, make sure that there's no life threats. By the way, if I got multiple multiskeletal injuries, I really want to make sure that I do a rapid trauma survey on these folks. All right. Now, again, this is they usually present with deformity, by the way, and again, this is a silver fork fracture or a Colles fracture, and again, so look for these things and look for contamination. And again, the 6 P's. I would know the 6 P's: pain, pallor, paresthesia, paralysis, pressure, pulses, and pulchothermia. The limb is cold to the touch, okay? So make sure that you know exactly what these 6 P's are, all right? Well, Scott, there's 7 of them. Well, actually, yes. But again, kind of paresthesia kind of goes along with paralysis as well, that tingling effect that you're going to get. Again, record your vital signs. Make sure that you do that. And if you suspect anything with paresthesia, is probably going to be highly suspected of a compartment syndrome, okay? And again, the pain is going to increase, by the way, when you move the limb. And unconscious patients with a swollen limb kind of assume that they've got a compartment syndrome going on anyway. Again, make sure that you get your sample history on these guys. Evaluate their pain. The 1 to 10 scale is what we want to use, okay? And that's before and after splinting and when you're doing your reassessments, okay? Again, do your detailed physical exam. Again, we touch everything, but do this on the way to the hospital, okay? Life threats on scene, and then let's get them moving. Let's get them packaged up. By the way, and I think that this is a good time to point this out. If I've got an isolated extremity fracture, I don't really need to, again, my vital signs are stable, everything looks good, there's no damage to the limb. Let's splint that thing appropriately and including pain management while you're on scene. Again, if the patient has instability or a life-threatening break, that's a whole different story and we need to get them going to the hospital. But again, if I've got a simple broken arm, vitals are all good, splint that thing right there. If I've got a leg fracture or an ankle dislocation, even a knee dislocation, again, splint it appropriately and provide pain management before you do the splinting, okay? Sports injuries, just remember, try to figure out how exactly it happened. Again, in the big areas is the shoulder, elbow, knee, wrist, ankle. Neck stingers are another one I would say I would put it in there. Again, don't let the gruesome musculoskeletal injury distract from your trauma patient management, okay? Make sure you check the pelvis, the femurs, the humerus, actually. You can lose a leader in each of the humerus, the upper arm as well. So make sure that you check these things. And you really do have to do a good job of that, okay? So again, now, limb realignment. There used to be the thing was, well, you split it in this place, you split it in place. What we found out was, yeah, well, actually, we should probably try to realign it, and the reason that we should probably try to realign it, not set it, but realign it, is because that way we cause less damage and injury. Now, a couple little rules with that. You can go until you stop when the resistance to the movement or the pain or discomfort. Now, there's going to be a little bit, okay? But again, if they go in, this is killing me, then you need to stop and then splint where it's at. But if you can realign these things, you'll be surprised how much it takes away from the pain factor, and it's a better thing for the patient, and it stops the additional injuries. So again, putting them into the correct position is a good thing, and it's okay to do a little bit of realignment in order to help manage the patient, okay? Now, by the way, for dislocation for extended periods, again, try to reduce the dislocation. Again, that we're finding out that we're doing a better job by doing that. Again, double check, by the way, when you're doing splinting or you do a realignment, pulses, motor sensation before, during, and after, okay? Before and after, definitely, okay? You want to chart those and make sure that you chart that in your report, okay? So again, immediate local cooling reduces local pain, swelling, and then general. By the way, so again, ice packs, cooled packs, they really do work and help and reduce pain. And gentle pressure by firm bandaging the splint might also help reduce the pain and swelling there. You got rigid splints. Again, this is what we usually have when we got a break. These are the guys that we usually try to use. The cardboard splint's kind of probably your more popular one. You got formidable splints. By the way, your SAM splints. Yeah, these guys are incredible. If you don't know how to use SAM splints, please see me. I will be more than happy to teach you. You will love them as much as I do. Your vacuum splints, these are air-filled. They take the air out of it, therefore it forms a rigid cast. They work really good. They take a lot of time to do, though, okay? So, again, just make sure that when you're immobilizing, you're checking your pulses before and after, and also make sure that you, when you're immobilizing your wounds, above and below the joints that are affected. I can't stress that one enough, okay? This would be an example of a vacuum splint. The other thing is they've got air splints where you actually blow it up kind of like a balloon. And again, those the problem is with those type of splints is you can sometimes cut off circulation with those guys. Pretty much, if you name it, it can be turned into a splint, okay? And don't be afraid to be creative on this. Pillow splints, they're comfortable for the ankle and the feet injuries. I caution you, though, the problem with a pillow splint is there's not much support around it. So you want to make sure to pad up around it as well with blankets to make sure that if you're going to use a soft splint like that, it still can move, okay? Femur fractures, again, these guys are your hair traction or your, if it's a, that's what we usually use, is the ratcheted splints. The KED splint is another one that works really good. The unipolar is a traction splint. The good news about a Sager, though, the Sager we can use on bilaterals and just use one splint. That's why a lot of people like that. Again, these videos, we actually have them up online. You can see those. This is an example of a real splint. Looks just like a hair traction splint. The thing with a real splint is, guys, is you can actually bend it. That's why they like that more than the hair traction. Again, other things you're going to need, by the way, your triangle bandage is your friend because it makes a great cravat, and then therefore, or Velcro straps you can use, but you want to use lots of them to secure the splint in place, okay? The fracture near the joint, again, you got to watch out for those nerve capsules. It's probably going to hurt a lot, and you can align the limb before splinting, and your best chance of ensuring good neurovascular function. Yeah, don't be afraid to do gentle alignment in order to get that arm. It's going to be better for the patient when they do that. Okay? Joint injuries, let's see here. Muscle. Connective tissue pain, again, usually these guys are not life-threatening. We're talking about connective tissue pains. Usually gentle circumferential bandage and ACE bandage works really good for these guys. Monitor your distal circulation, and then again, put some local cooling. An ice pack works really good for these guys. Pelvic fractures. Oh boy, here we go. They should be considered high priority. Now they got all these. They got the type 1 fracture is not involving the pelvic ring, and then type 2 is actually a single break in the pelvic ring. Type 3 is high energy. Type 4 is when you got the acetabulum broken in there. And I think thought I had a picture in there. No, I didn't. Now again, if you got this, you can lose in excess of 2 liters. I'm going to go as far as to say 3 liters, okay? So the hip dislocations, injuries to the bladder, you can have all these damages caused by a pelvic fracture, okay? Now, there's all kinds of wraps, and again, I'm kind of used to the sliding the sheet under and bringing the sheet up and tying the sheet around. I think that's an effective one. There's a lot of people that would disagree with me. They'd rather put on this thing, the T-pod. Yes, it stabilizes, it holds it in place. My problem with the T-pod is it takes forever to get put on. Well, comparatively to the sheet method. And the first thing they're going to do once they get into the trauma bay is take this thing off. And again, the sheet, it's much quicker to get on and off. Now the argument is the T-pod holds it in much better position. If you put the sheet in the right place, it does the same thing. But again, if your department uses a T-pod, by all means, and you can put it on fast, by all means do so. All right. So again, your femur fracture, again, if it's a single isolated femur, again, you immobilize, gentle transport. And again, a little bit of traction, by the way, goes a long way for your femurs, okay? Now, what the femur, by the way, when I say femur, what I don't mean is the head of the femur, or otherwise known as a hip fracture. Yeah, these guys here, they hurt. Yeah, a midshaft femur, by the way, usually takes a lot of energy to create, so stop thinking about those underlying structures, okay? Don't, again, I repeat it again, don't use a hair traction Sager splint on a hip fracture. Yeah, it's not going to work. It's going to hurt a lot worse. So what do you do, by the way, for a hip fracture? Usually the stretcher is fine. Put them on your folding, not your folding stretcher, but your scoop stretcher. Transfer them, and again, or use a soft stretcher to bring them up to the. And then again, pad the area appropriately where you limit the movement of the area. Okay. And then your buckles and straps on your stretcher should be fine. Okay. Now your tibia and fibula. And by the way, I've seen people do the hip fracture where they put the board splint all the way up to the armpit. But it doesn't really do any good. My experience has been it doesn't. Tibia fibula, usually, remember, both of them are broke. We consider that a long bone fracture. Fibular fractures are associated with the knee or the ankle, by the way, so those things can happen. Again, make sure usually if air splint or a vacuum splint, or again, the padded splint works really good for these guys. Clavicle, swing, and the key word here is swath. You got to have that strap around the chest wall that holds the clavicle in place. Again, the humerus is kind of difficult to immobilize at the proximal end. Usually, sling and swath is your best thing here. Just don't tie the swath so tight but again, go around both the upper and the upper arms. Immobilize it to the body. Okay, it's probably your best bet there. Radius and ulna fracture, again, these guys, pad them up, use your cardboard splints, they work really good. Your Colles fracture is where the wrist is turned at an unusual angle, and it has kind of like a silver fork deformity. I showed you guys that a little bit earlier. Again, remember that if you do have a radius and ulna fracture, those are considered, if both of them are fractured, we consider it a long bone fracture. Again, a rigid splint usually works good. We just remember to pad the splint to where they're not moving. The idea is we don't move the extremity once it gets into the splint. They're using the SAM splint. And again, by the way, sand splints, you can sit there and form to whatever break they might have. Go around it with the gauze. Again, it works really, 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 really good. Your hips, again, mobilize on a long spine board. Ow! Okay. Guys, a scoop stretcher, I think, is a much better choice for this, okay? Unless you've got some neck involvement, and even then, if you've got neck involvement, I'm talking about cervical involvement, probably just doing the C-collar and putting them on the stretcher is probably going to be your better bet. Again, I would say lose the long spine board and use a lot of pillows and blankets on the stretcher, okay? That would be my recommendation on that, okay? Do not attempt a reduction unless there are other serious injuries involved with the hip, by the way. Yeah, you don't really want to do that. Your knees, again, the problem is that they have the possibility of never walking again. So, and then you've also got the popliteal artery, which usually gets caught up in that knee dislocation, okay? And immobilizing the position, and a lot of times, again, you're going to need a lot of splinting, and it's going to take a little bit of creativity. Patellar knee dislocations, I've had a bunch of those, and usually the knee's in a flex position, and the patella goes laterally. Okay, again, if the dislocation cannot be reduced, and by the way, a little bit of manipulation, remember all the tendons in that area, you're going to get a little bit of movement is probably going to pop this knee back in, okay? And it's one of those, they'll probably scream really loud, but once it pops back in, they'll be like, oh, I feel so much better. And that's been usually, again, by the time we moved them to the stretcher, usually it would pop back in and it'd be, oh. But again, if not, you're going to have to do some creative splinting to make sure that you don't move that leg, okay? Again, ankles, pillow splints work pretty good on these guys. Again, wrap it up, use an ace bandage, go around, make sure that you got access to the toes so that you can make sure that you're not cutting off circulation. Shoulders, by the way, is the proximal humerus lateral shoulder. Again, in anterior dislocations, usually when everything comes forward or it squares off. And again, most of the time, the best way to immobilize these is your sling and swath, especially in the upper extremities. Probably, again, let the sling and swath support the weight on the other side. Elbow, by the way, we've got a lot of problem with nerve injuries here. Because remember, there's a lot of nerves that go into the small little muscles that do our hands and fingers. And again, usually a padded splint, rigid splint works probably your best there. Just in a padded, rigid, or vacuum splint work good. Again, make it to where they can't move it. Fingers and toes, splint it to a good finger and toe is probably your best bet there. Okay, I've seen some people use tongue depressors and then wrap the finger. That's acceptable to do. Most of the time, guys, I wrap the bad one next to the good one, and then allow that to serve as the splinting device until they get to that. And by the way, when they go to move the bad one, believe me when I say they'll stop moving it. Again, soft and connective tissues. Again, usually a little bit of cold. Again, but it can, remember, you can have tissue damage that actually, ankles are probably the big ones, and treat them just as if they are fractures, okay? So use the same methodology in which to treat them there. Again, the connective tissue is the biggest thing. Now, medicines, guys, especially if it's an isolated and they're stable, don't make them go through the pain. Again, give them some fentanyl, give them some morphine. Again, fentanyl given intranasally, by the way, are really good with children, but really good with adults. So again, if you don't want to get the IV started, you can give the fentanyl intranasally. Okay, it's okay to do that. All right, it will transfer. It will go over. Give them something before you start giving them any type of treatment. Again, you don't. If we're not in a rush, there's no life threat. It's okay to slow down and take your time and give them something for pain, okay? That's the key thing there. Don't be afraid to slow down if there's not a life-threatening injury or a limb-threatening injury. It's okay to slow down and do it, splint it correctly. You're going to prevent injury and further damage by doing that. Pediatrics, remember, kids usually don't break bones unless there's a significant force or problem. So again, report any suspicious things, by the way, to law enforcement, especially if you keep going to the same kid that continually problems. If you keep going to the same kid, you kind of got to go, wait just a minute here. Again, your athletic injuries, again, injuries to the knee, ankle, they can be serious. They're kind of common calls to the EMS. But remember, probably this is going to let the athletic trainers, by the way, most of them have the athletic trainer. They will call you over if they need to be transported further needs to be done. Nowadays, a lot of the athletic trainers are actually EMTs. It's kind of a growing trend within that industry. Again, the injured athlete becomes the EMS patient under the medical direction and protocols, and at that point, you're going to assume care for them. Again, your athletic injuries, usually your ice is going to rest the extremity, ice for the first 48 hours. Make sure you got compression on there and elevate it for venous drainage. So again, the refusals? Again, we don't have x-rays. If we had an ultrasound, I'd say maybe, hey, we can take a look at the bone. But again, assuming that if you're going to do this, by the way, get in touch with their medical direction. And again, I'm not a big fan of getting a refusal. Because again, this is one of those bags of crap deal. If you say, no, you'll be okay, and then 2 days later they end up with a fracture. Yeah, that never ends, and I repeat, never ends well. And especially, let's say it's a hip fracture, they put her back in bed, she doesn't want to go. That one, I have seen so many paramedics fired over, it's not funny. Gang, yeah, if it's an older lady, unless they're standing up, walking around, doing everything, you get to take a ride with me, okay? So your psychological support, again, remember that, make sure that you let them know exactly what you're doing while you're doing this. Again, pain management goes a long way, okay? Long way. All right, so we went a little bit long on this, but again, splinting is actually, I think this is one of those things that I prefer to do in the lab, and I very much prefer to do them where you guys get to sit there and play and practice and come up with different things in order to do it. I think it's a lost art that you really should dedicate some time in which to do. When you've got EMT students, by the way, this is a great time to break out the bag of splints and splint them, okay? So again, constant monitoring of these patients. Remember, always check your pulses, pulse motor sensation before you splint, after your splint. That's kind of an important one. All right, guys, we're going to talk to you on the next one.